welcome to the deep dive. Today we're taking a really fascinating journey into vascular surgery,
hmm
specifically looking at how the technology used to, see inside the body is transforming things in the operating room.
Yeah, it's a huge shift.
We're going to unpack the exciting move towards advanced 3D imaging and the growing role of image guidance during procedures.
And our goal today really is to give you a clear picture of this evolution, how these cutting-edge technologies are making operations safer and getting better outcomes for patients.
Right. Better and safer.
We'll be drawing from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, focusing on, the future of imaging chapters.
Okay, so let's start maybe by thinking about where things were. Not that long ago, really. Surgeons relied heavily on those portable C-arm X-ray systems.
Oh yeah, the mobile units you see wheeled around, standard stuff for
But
years.
now we're seeing a real move towards, well, much more sophisticated imaging platforms.
Absolutely. And that's really shown by the rise of the hybrid operating room. Think of these as specialized suites that bring everything together.
Everything, like open surgery tools and the minimally invasive stuff.
Exactly. Open surgery, endovascular capabilities all in one place. It avoids those risky patient transfers between, say, an angio suite and an OR.
Which must be critical in emergencies.
Hugely important, especially in acute situations, it directly translates to better outcomes.
And these hybrid ORs, they're not just like a nice to have anymore. Sounds like they're becoming essential as procedures get more complex.
That's right. They're increasingly critical, and there are really two big drivers here.
Okay.
One is boosting how effective the procedures are, making them better.
Makes sense.
But the other, just as important, is minimizing radiation. For the patient, of course, but also for the whole surgical team.
Right, that radiation exposure is a big deal.
Yeah.
Okay, so let's get into the specifics, starting with X-ray tech, the sort of backbone, and how it fits into these hybrid rooms.
Well, traditional 2D X-ray fluoroscopy and angiography, they've been, and honestly still are, incredibly important.
Still relevant then.
Definitely. Their big strength is high resolution, real-time images, fantastic for seeing tiny blood vessels clearly, quickly.
Now, those portable C-arms you mentioned,
Yeah.
they've had some serious upgrades too, haven't they? They're not the basic units from years ago.
Oh, absolutely. A major shift was moving from the old image intensifiers to these flat panel digital detectors.
And what's the benefit there? Just better pictures?
It's a dramatic improvement. Better image quality, yes, but also better signal-to-noise ratio,
Likely.
less grainy images, more detail, and wider dynamic range so you can see bright and dark areas well. Plus, they reduce those geometric distortions you used to get.
And it's not just the detector part, right? The part that actually makes the X-rays, the tube, that's improved too.
Indeed. Newer mobile C-arms have much higher power generators, maybe around 25 kilowatts now.
Wow.
And better cooling systems so they
Hmm.
can penetrate better, which is key for, larger patients. And it also means you can image for longer without interruption. Really vital for complex endovascular cases done with catheters.
It's kind of amazing they're still called portable with all that power.
Yeah.
I think I read somewhere about 3D imaging creeping into mobile C-arms too.
Yeah, that's interesting. Mobile C-arm 3D has seen use in orthopedics, maybe bronchoscopy.
But not so much in vascular yet.
Its routine clinical use for vascular procedures is, well, still pretty early days, but it's definitely evolving.
Okay, so maybe not standard yet, but watch this space. What about features that are available now in these mobile units?
Well, things like image fusion and overlay capabilities are really relevant now.
Image fusion, like layering different images.
Exactly. You overlay, say, a pre-op scan onto the live X-ray, gives you more context. For many practices, the portable C-arm is still the main tool, or at least a critical backup to the fixed systems.
And they're popping up outside hospitals too, right? Office-based labs.
Absolutely. Portable C-arm suites are increasingly used for office-based vascular practices. As the tech gap narrows between them and the big fixed systems, they become a really practical, cost-effective option for outpatient work.
Okay, now let's shift to those fixed C-arm systems. The centerpieces of the modern hybrid OR. What's the big deal with them?
The fundamental advantage is doing high-res angiography, imaging vessels with contrast right there during complex open surgery if needed.
So, no need to move the patient mid-surgery for better imaging.
Precisely. It's a game changer for coordinating treatments, can lead to much better outcomes.
Having that power right there. And you said these hybrid ORs can vary a lot.
That's a really key point. Hybrid OR can mean different things. A true, modern, high-end one usually has a fixed C-arm system that can handle everything open, endovascular hybrid approaches.
And some of these fixed systems are on robotic arms. That sounds very sci-fi.
It does, doesn't it? But the robotic arm mounting adds incredible versatility.
How so?
It lets you position the imaging system exactly where you need it, when you need it, around the patient. Super helpful for complex cases.
Okay, but with all this powerful X-ray flying around, radiation safety has got to be front and center.
Absolutely critical. Monitoring the dose to the patient, yes, but also comprehensive training and awareness for the whole OR team. It's paramount and, honestly, sometimes underestimated.
You mentioned LRI before. What's that again?
LRI stands for as low as reasonably achievable. It's the golden rule.
Keep the dose down.
Keep it to the absolute minimum needed to get the clinical information. It has to be fundamental to training and practice, not just, an afterthought.
Seems obvious, but you mentioned data suggesting maybe training isn't quite there yet for vascular surgeons.
Unfortunately, yeah. A recent survey found a significant number of trainees felt they lacked formal radiation safety training or even awareness of acceptable exposure levels.
Wow.
It really highlights an urgent need to beef up radiation safety measures, protect everyone involved.
And figuring out where the radiation actually goes in the room, the scatter, that's not always intuitive.
That's exactly right. Understanding scatter patterns is tricky. Traditional training might not always give you that practical feel for the risks.
But new tech might help with that?
Yeah, there are some interesting studies using personal wireless dosimeters, little monitors people wear.
To map it out.
Exactly. To map the scatter patterns in real time in the OR, that kind of data could be huge for making safety training much more effective, much more visual.
Okay, shifting slightly. Setting up one of these hybrid ORs sounds like a massive project. What are the big things to consider when designing one?
Oh, it's hugely complex. You have to think about what procedures will be done there. Is the room big enough? Floor space, ceiling height?
Location too, I imagine.
Location in the hospital, definitely.
Yeah.
Proximity to other critical areas. And crucially, you need everyone involved from the start.
Everyone meeting.
Surgeons, anesthesiologists, nurses, the X-ray techs, working closely with experienced architects and the equipment vendors who get these unique requirements.
So it's a massive team effort.
Absolutely. Getting the right staffing, trained OR managers, hybrid-savvy nurses, skilled techs, and then comprehensive training for everyone. Essential. Building a fully functional service can take months, even years. It needs seamless collaboration.
It sounds like way more than just plugging in some fancy machines.
Precisely. The imaging system gets the attention, but honestly, configuring all the other stuff,
Like what?
surgical lights, equipment booms, anesthesia systems, maybe even bypass pumps, getting all that right, plus the staff training on everything, that's often overlooked but can be even more challenging than installing the C-arm itself.
And I guess all these different systems, scheduling, imaging, monitors, they all need to talk to each other.
Absolutely critical. Tight integration of scheduling, AV, imaging archives, PACS, patient monitoring, hospital IT. It's vital for seamless access to all the patient info you need during these complex interventions.
Okay, so that covers the X-ray evolution and the complexities of the hybrid OR setup. Now let's get into what feels like the really cutting-edge stuff. Advanced 3D imaging and image guidance. This is where it gets exciting.
It really does. Not so long ago, preoperative CT or MRI was mainly for diagnosis, deciding what to do.
Right. See the problem?
But now, their role is way bigger. Surgeons routinely use software to create these multiplanar reconstructions, like slicing the 3D image any way you want.
Yeah, these cool 3D models.
Exactly. Volume-rendered reconstructions, you can spin them around, look from all angles, allows for meticulous planning for both endo and open procedures.
And this detailed planning led to specific software tools.
Yeah, especially with the rise of endovascular stent grafting, fixing aneurysms minimally invasively. That spurred development of specialized software for advanced visualization, even virtual planning of the whole stent graft procedure.
Like a flight simulator for surgeons.
Sort of.
Yeah.
A surgical rehearsal in the digital world. And the newest hybrid ORs are taking this further, integrating these capabilities right into the room.
How? What kind of tech?
Things like cone beam CT, which we'll get into, and sophisticated image fusion. That's overlaying the pre-op CT or MRI data onto the live imaging during the case.
Like a surgical GPS.
Pretty much, a GPS for inside the patient's body.
Which means the quality of those initial scans becomes even more important, right?
Absolutely paramount. The
Yeah.
technical quality, the specific protocols used for the pre-op scans, it's not just for a diagnosis anymore. It directly guides the surgery.
So you need really good images to start with.
High resolution, thin slices, essential for accurate 3D rendering and fusion. Like if you're hunting for a tiny type 2 endoleak, persistent flow after aneurysm repair, you need scans covering the arterial phase and delayed phases to really see the flow dynamics.
So those detailed pre-op images become a roadmap overlaid onto the live view during surgery, guiding the surgeon.
Precisely. You identify targets on the pre-op CT, mark them, and then that info gets digitally overlaid onto the live fluoro image, guides things like embolization, blocking off vessels.
Makes it more precise.
Much more precise. And it helps optimize radiation and contrast use, too. Big benefits there.
And this isn't just for catheter-based stuff, right? You mentioned using it for open surgery planning, too.
That's right. Even for open procedures, you can use surface rendering of a CT scan. Shows external features, maybe old scars.
How does that help?
You can use it to meticulously plan the incision after doing what's called surface-to-surface co-registration, aligning the CT surface model with the patient on the table. It's all about maximizing precision, minimizing invasiveness.
So summing up the benefits of all this pre-op imaging and planning.
Okay, key benefits. Helps pick the right device size. Helps choose the best C-arm angle to avoid parallax distortion, ensuring accurate placement.
Right, that visual trickiness.
And maybe most importantly, image fusion gives you that crucial 3D roadmap in real time during the intervention.
But the body isn't static, is it? The heart's beating, patient's breathing.
Exactly. The aorta, for instance, subtly shifts shape and position with every heartbeat, every breath.
So the map needs to account for movement.
Well, that's where dynamic imaging comes in. Using CT and MRI that capture motion is becoming increasingly important to really understand and guide interventions for tricky things like aneurysms and dissections.
Okay, let's dig into one of those intraoperative techniques you mentioned. C-arm cone beam CT, or CBCT. What is that exactly?
Okay, think of your standard fixed C-arm in the hybrid OR. CBCT basically adds the ability to get 3D images right there during the surgery.
How does it do that?
The C-arm rotates around the patient, taking a series of 2D X-ray shots. Then a powerful computer reconstructs those 2D projections into a 3D volume, like a CT scan, but done intraoperatively.
And this isn't brand new tech overall, right? It's been used elsewhere.
That's right. High-contrast 3D angio and CBCT have been staples in neurointerventional suites, for brain stuff, and in interventional radiology for a while now.
But it's newer to the vascular OR.
Its adoption in the vascular OR is more recent, but it's a rapidly growing trend.
I've seen different names for it, though. Dynas CT, Expert CT gets confusing.
You're absolutely right. While the generic term is CBCT, the different companies use their own brand names. Syngo Dynasty, Expert CT, Endovascular CT, you hear those a lot.
Good to know.
Yeah, it's important to be aware, understand the specific system's capabilities, and the training needed.
So CBCT is becoming a valuable tool in the vascular OR. How's it impacting procedures?
It's proving really versatile. Potential to significantly enhance both open surgery and endovascular stuff. Could even be crucial for things like flexible catheter robotics down the line.
A gateway technology.
Kind of seen that way, yeah. A gateway to bringing more sophisticated CT-like imaging right into the OR environment.
But again, more X-ray use means that radiation concern doesn't go away.
Absolutely. It remains a critical consideration. The growing use of X-ray techniques means we have to keep developing better radiation monitoring and dose reduction methods.
And keep looking for alternatives.
And keep exploring those radiation-free alternatives, yes. Optical tracking, electromagnetic tracking, ultrasound, MRI, especially for complex cases. That research is vital.
Okay, you also mentioned CT image fusion and guidance. How does that work practically?
Well, ideally, the dream scenario is having a full CT scanner in the OR for immediate post-procedure checks.
Check the stent graft placement right away.
Exactly. Evaluate success, maybe prevent reinterventions. But until that's routine, what we have now is the ability to take a 3D DICOM dataset, the standard image format, and fuse it, digitally align it with pre-op CT or MRI data.
And the main goal of that fusion is less radiation, less contrast during the actual procedure.
Precisely. Using 2D, 3D, or 3D, 3D fusion lets us leverage the detailed anatomy from the pre-op scan, often a CTA, CT angiography, without needing lots of extra intra-op contrast or radiation.
Could you break down that 3D fusion process step by step in the OR?
Sure. Typically, you acquire a low-dose, non-contrast CBCT scan during the procedure. Then, using a workstation in the OR, you co-register or align that intra-op 3D dataset with the pre-op CT or MRO.
Aligning the two 3D pictures.
Right. Once they're accurately fused, the structures you marked on the pre-op scan target vessels, landing zones for stents, get overlaid onto the live fluoro image during the intervention.
It's like that personalized GPS overlay again, guiding the surgeon in real time.
Exactly. And a big plus of 3D fusion is you often don't need more contrast during the intervention because you're matching anatomy between the two 3D sets.
How do you verify it's accurate?
You can use things like IVUS intravascular ultrasound or maybe low-dose CO2 angiography to check the fusion. Plus, there are automated algorithms emerging now that can automatically identify and overlay key vessel landmarks.
You gave the EVAR example earlier, endovascular aneurysm repair. Can you walk through the workflow for that with 3D fusion?
Okay. Patient gets a detailed outpatient CTA beforehand. In the hybrid OR, after prep, we do a low-dose non-contrast CBCT. Then fuse that CBCT with the pre-op CTA on the workstation.
Software helps align them.
Yeah, algorithms can identify the aorta, major branches.
Yeah.
Once fused and verified, all those segmented vessels appear as an overlay on the live fluoro, even before any contrast is injected.
How does the system ensure the pre-op scan and the intra-op scan line up right? What does it match?
Usually, the initial fusion relies on aligning stable bony structures visible in both scans, ribs, vertebrae, pelvis.
Assuming if the bones match, the vessels nearby should too.
That's the assumption. But it has limitations. Patient positioning might be slightly different between the pre-op scan and the OR table.
Ah, right. Lying slightly differently.
Exactly, which is why more refined techniques use vascular wall calcifications.
The bones of the vessels.
Kind of. They're common in older EVR patients and can provide more precise alignment of the actual vessels than just using bony landmarks.
You also mentioned a 2D fusion technique. How's that different?
2D 3D aims to directly co-register the pre-op 3D images, CTA or MRA, with the live fluoro images, skipping the intra-op CBCT step.
How does that work?
You take two fluoro shots from different angles, use those to digitally reconstruct radiograph simulated X-rays from the pre-op 3D scan, then match those simulated X-rays to the real fluoro images.
Simpler workflow?
Potentially simpler, yeah, because no CBCT. But the accuracy still needs more validation compared to 3D methods.
So it's a constant balancing act, simplicity versus accuracy.
Absolutely. Finding that sweet spot. For now, until the algorithms are rock solid and fully automated, surgeons often use a tiny bit of dilute contrast or maybe CO2 angio just to visually double-check the fusion accuracy before deploying anything critical.
Okay, now let's switch to MRI for fusion and guidance. That's interesting because no radiation.
That's a huge advantage, especially for patients with kidney problems where the iodinated contrast used in CTAs can be risky.
Right, contrast nephropathy.
Studies show using MRI fusion can cut procedure time, radiation dose, and the amount of iodinated contrast needed in endovascular procedures.
For patients with poor kidney function, MR angiography is a safer bet for that pre-op imaging.
Exactly. Contrast-enhanced MRA, often using iron-based agents like ferumoxytol, can frequently be done safely even in end-stage renal disease. And those 3D MRA images work great for intra-op fusion.
What's a typical MRI protocol for this? Any specific sequences?
Usually standard vendor protocols, maybe slightly tweaked. For patients without kidney issues, we might use gadolinium contrast. For those with renal insufficiency, ferumoxytol is preferred after screening for iron overload.
What kind of images do you get?
We typically get arterial, venous, and equilibrium phase images shows different flow info, and often a sequence called Vibe-E, which helps see bony landmarks better for the fusion process.
And the MRA CBCT fusion process itself, how does it compare to using the CTA?
Similar workflow. Import the pre-op MRA to the OR workstation, do an intra-op non-contrast CBCT, then co-register the two datasets using the fusion software.
Is it harder?
It can sometimes need more manual tweaking than CTA fusion. MRI and CBCT images look quite different. You often rely on matching vessel contours, calcifications if visible, or maybe indwelling devices seen on both. Tends to be a bit more labor-intensive.
A bit more work, but worth it for those patients. Once it is fused, how is the info used?
Same idea. Key landmarks, vessel origins, stent landing zones are marked on the pre-op MRA. Those marks are then projected onto the live fluoro in real time.
And they move with the C-arm.
Yep, they dynamically update with C-arm angle, table position, zoom changes. There are compelling studies showing this 3D MRA fluorofusion works well for complex aortic cases in patients with renal insufficiency without hurting their kidney function further.
That's a massive benefit for a vulnerable group.
Yeah.
You also mentioned MRV magnetic resonance sonography for veins.
Yes, MRV is becoming really valuable for venous occlusive disease vein blockages. It's great at characterizing clots, maybe even aging them, and helpful in tricky central venous access cases.
And again, trying to avoid contrast in kidney patients.
Absolutely. There are non-contrast MR techniques like time-of-flight MRA or 3D steady-state free precession. We can also use ferumoxytol for blood pool imaging to see veins well.
Tech keeps improving there too.
Definitely. Things like respiratory-gated non-contrast space MRA give even better images of central veins faster, bringing MRV into routine use without contrast risks.
What's the idea behind using MRV for intervening on blocked central veins?
The hypothesis is that MRV, especially with delayed imaging, might visualize subtle structures around the blocked vein, like the vasa vasorum, the vein wall's own blood supply.
Information you wouldn't get otherwise.
Maybe not from standard venography. This detailed info can then be overlaid onto fluoro using fusion to provide better 3D guidance during complex recanalizations, reopening blocked veins.
Giving the surgeon more insight into the vessel wall itself.
Exactly. You optimize the 3D fusion, aligning bones or devices on the CBCT with the veins on the MRI. The CBCT also gives soft tissue info, helps troubleshoot, understand catheter position, rule out perforation.
And then the overlay guides the recanalization.
Right. Marked landmarks and the vein center line from the fused MRI CBCT get overlaid onto live fluoro, tracking automatically with C-arm and table movements. Studies suggest this MR overlay enhances planning, visualization, and correlates with success, even in previously failed attempts.
But there's still that issue. The pre-op scan doesn't show how vessels change once you put wires in, right?
That's a crucial limitation. Vessels do deform or shift during interventions. That's why we often use additional real-time tools like IVUS intravascular ultrasound.
To see inside the vessel right now.
Exactly. And IVUS images can even be co-registered with fluoro or venography for a more complete dynamic picture. The future vision is really about integrating all this multimodality data in real time. We're even seeing initial intra-op MRI or CT setups.
It sounds like we need a unified platform to manage all this data effectively.
A user-friendly, integrated system for acquisition, fusion, guidance. That's essential to realize the full potential.
Okay, switching gears again slightly. Not all vascular work is interluminal. What about needle procedures, like embolizing type 2 endoleaks?
You're right. Things like percutaneous embolization for type 2 endoleaks often involve precise needle placement, usually from the back, translumbar, or abdomen, transabdominal, historically guided mainly by bony landmarks on fluoro.
But 3D guidance is helping here too.
Absolutely. For 3D lethal guidance, you can do an intra-op CBCT, then fuse it with a pre-op CT or MRI where the endoleak and feeding vessels are mapped out.
Aligning things even if the patient's position changed.
Yes, it can align previously placed stent grafts accurately, even if the patient's, say, prone. The target endoleak is marked on the pre-op scan, creating a virtual needle path overlaid on live fluoro as the needle advances.
Like a virtual targeting system.
Kind of. Some systems even have a laser crosshairs on the detector to guide the skin entry point for a perfect bullseye trajectory, and that virtual path stays accurate regardless of C-arm angle. True 3D guidance.
How do you confirm placement?
Aspirate blood from the leak, or do another quick CBCT. Then you place your guide wire and sheath for the embolization.
That precision must make a big difference for those tricky needle procedures. Okay, looking at the bigger picture, what are the key challenges still remaining, and what are the next steps?
A big one is that current fusion doesn't usually count for vessel deformation caused by wires and devices during the procedure.
The live changes.
Right. Two main approaches to tackle this. One is getting more intra-op 3D data after deformation and re-registering. The other is developing smart deformable registration algorithms using real-time biplane fluoro to predict vessel shape changes.
And correcting for patient movement.
Also need better automatic correction for patient movement during fusion. Practically, we need ongoing optimization of pre-op scan protocols, and crucially, comprehensive, continuous training for techs and surgeons on these complex tools.
Can't forget the human element.
Never. We also need to keep emphasizing the dynamic nature of vascular disease, using dynamic CT-MRI appropriately for planning and surveillance. Think 40 flow MRI faster now, with new tech giving objective flow data for things like aortic dissection.
You mentioned non-radiation alternatives earlier, too.
Yeah.
Optical and electromagnetic tracking.
Yes, actively being explored. EM tracking uses sensors and instruments. Optical scanning maps the patient's surface.
Potentially cheaper. More widespread.
Could be more cost-effective, maybe usable in almost any OR for optimizing things like minimally invasive cardiac incisions.
And that fiber optic real-shape tech sounded really interesting. Tell me more.
Right, FFORS. While fluoro is still king in vascular, unlike other fields pushing harder to cut radiation, FFORS is a promising recent step to reduce reliance on it.
How does it work? Visualizing devices without X-ray.
Basically, yeah.
Yeah.
Offers real-time 3D visualization of device shape and position inside the body with much less radiation. It uses light and optical fibers.
Light.
Measures strain based on how light reflects off tiny density fluctuations in the fiber as it bends. Gives real-time, high-res 3D shape, often color-coded.
And you can overlay that on scans.
Exactly. Integrate it with pre-op CTMR for enhanced navigation and precise positioning.
This all seems to be pointing toward more precise, less invasive procedures, maybe involving robotics. How does imaging tie into endovascular navigation and catheter robotics?
Well, the ultimate goal is control and precision beyond manual techniques. Robotic catheter systems are a big leap there. Better accuracy, maneuverability, stability.
But the robot needs to see, right?
Absolutely. Seamless integration with real-time, high-quality imaging is crucial for making these robotic procedures fluid and safe.
Is there a system out there now? How does imaging work with it?
There's one main FDA-approved system for peripheral interventions, Corindus. It uses standard fluoro but doesn't yet have, say, an actuated catheter tip controlled by the robot or fully integrated advanced imaging.
But that's the direction things are heading, integrating robots and imaging.
Definitely. Lots of R&D focus there. Imagine planning a path on a 3D model from a CT, then having the robot semi-autonomously move the catheter along that path. Assisted navigation.
Combining robotic precision with 3D imaging guidance.
That's the transformative potential. Studies using EM tracking in lab models have shown this assisted navigation is feasible, getting real-time feedback on catheter location, shape, motion via embedded sensors.
So the system knows where the catheter is and can correct its course.
Yes. EM triangulation allows feedback, correction, even autonomous movement along a preset path. Future navigation will likely lean heavily on non-radiation tracking like optical fiber or EM sensors.
Okay, finally looking ahead. The future of these hybrid ORs. Where are things going?
The latest ones are clearly moving towards tighter integration of multiple imaging types to guide ever more sophisticated, minimally invasive therapies.
And the impact gets bigger when combined with...
When combined with novel catheter therapies and minimally invasive robotic surgery solutions, that's where the synergy will be huge.
But usability is key.
Absolutely critical. Vendors need to make platforms more user-friendly, intuitive for integrating all this data. Ideally open, vendor-neutral architecture so systems talk to each other.
And training.
And prioritize consistent, effective user education. Dedicated learning pathways are essential.
What about even more advanced imaging actually in the suite?
Yeah, we're seeing more installs of fully functional, conventional, multi-slice CT scanners within future hybrid ORs, often on rails.
A real CT scanner in the OR.
Yep. Immediate intra-op cross-sectional imaging. Potentially transformational for image-guided surgery? Imagine diagnosing and treating an unstable PE or aortic dissection immediately, same room, no transfer.
Wow, that would change things, especially for trauma or emergencies. What about MRI in the suite?
Also being explored. Big technical challenges, though, magnetic shielding, patient transfer systems. Very attractive concept, especially for neurosurgery. But maybe fewer direct uses currently in routine cardiovascular work, though research continues.
It really feels like we're on the verge of some major changes in vascular surgery.
Indeed. The future for both endovascular and open surgery looks incredibly bright, poised for a revolution driven by these imaging and navigation technologies.
So just to quickly recap our deep dive today, we've traced imaging from portable X-rays right through to sophisticated 3D, image fusion, and emerging tech like robotics and fiber optics.
And for you listening, the key takeaways are really about improved safety, better effectiveness, and that crucial push to reduce radiation, those real aha moments showing the progress.
And it's clear this integration of multiple imaging types, plus future real-time intra-op imaging and robotics, will keep reshaping the field.
Which leaves us with a thought for you to ponder. With innovation moving this fast in imaging and navigation, how might these technologies fundamentally change how vascular surgery is done and maybe more importantly, how patients experience it in the next 10 years? Think about the implications: more precise, less invasive, maybe even radiation-free procedures becoming the norm.